in a very polite and maybe British manner, you said to people, wake the hell up. I don't think that you were throwing mud, but I really do think that you spoke from the heart. And what you were conveying was a need to act now. I'm in the minority of MS neurologists that feel that we need to hit as hard as we can, as early as we can. And yet, as you point out in that video, the evidence is starting to become insurmountable, pointing in that direction, that is in fact the best approach that we can have.
Yeah, I mean, number one, thanks and good morning. Look at you with your coffee. I don't want to frighten somebody. I want to make them aware. And I think it's really sad. I think a lot of doctors and nurses sort of, they're there, don't worry. And it is a big, hairy, scary thing. You've gone from, your life's going that way, and now it's just going that way. But I do think, frankly, it's incumbent on you guys to bite the bullet more. I mean, I don't know how when somebody gets a cancer diagnosis, I'm sure they don't try and like ease them into it. This is serious. We need to do something.
Hey! And today I'm joined by a friend of mine across the pond, Dominic. If you're not familiar with Dominic, you don't know his channel, you're missing out. And so it's a great pleasure that we get a chance to talk. I just reached out to you because I just watched a very, very impactful video that I think you just published on your channel.
Yeah.
It was a really, really striking discussion that you had about the journey of MS, and in specific, a cultural fear of treating the disease aggressively.
I'm Dominic. I'm 54. I'm half Canadian, even though I don't sound it because I've lived most of my life in the UK. I was diagnosed with MS when I was 24. I was very fortunate in some. I've been really lucky, Aaron. In fact, in many, many ways, I think the chips have fallen for me. I've never won a lottery or a draw at the school fete or anything, but I've got MS. That's not lucky. But in the context of MS, I could be doing a whole lot worse. And do you know what really got me for this video? I was doing some work for an MS charity, and I was chatting to this young woman, and we had spoken previously, but never face to face. And she's 30. She was diagnosed when she was 16.
Mhm.
And all of a sudden, and she got there, let's go really gently. Let's just not do this. I don't want to scare you. Yeah, da 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 da. And at 26, it was like being, to me, the MS sort of tipped up behind her and went, boff. And there's no going back. This is what drives me insane, is once that damage is done, there's no going back. So she's 30, she's uses walkers, wheelchairs, things like this. And she said, it was a pretty rapid turn, and there's no guarantee. As you know as a doctor, and as I know, I see many people, it doesn't automatically follow, but the data shows unequivocally, it shows that the sooner you're started on high efficacy drugs, the better your long-term outcomes are. And Aaron, I'll say this, it's not a sexy disease. It's not somebody coming screaming into A&E with a heart attack or being diagnosed with cancer. So I think it's really easy for professionals to go, but they haven't got it. It's going to disable them through their life. Sorry, I'll get off my soapbox.
No, you're spot on. And I sometimes call this the devil's trick, because the human being feels the very best they're ever going to feel. They're the youngest they're ever going to be the first 5-10 years of the disease. And that is, in fact, pathologically when the most damage is done. So when someone is given a new diagnosis of MS, they don't necessarily feel horrible, and they don't know what's coming. And if their doctor says to them something to the equivalent of, it's not that bad, we don't have to intervene, or we don't have to intervene seriously, it's probably something that they want to hear. And so I think the trick is to get someone to understand that we're not trying to treat them for them at that point in time. We're trying to treat them for 30 years later.
But this is the thing. You think about that. So few, not as many as you'd like of your colleagues think about it like that. They're thinking about the now, and there's two things. There is the now, but there is the future.
Yeah.
And I think this is a real issue because it's impossible to treat for the future if you're not thinking about it.
When I sit in a room with a family, I'm trying to help that family understand this point. And I'll say things like, let's channel the 30-year from now you, bring them forward. So if you 30 years from now were sitting next to you, they would scream and yell at you. They would stomp their feet or they would slap you because the disability they have accrued over the last 30 years, they can't do anything about. You now can do something about it. And it's even worse when I talk to my colleagues. I'm a pariah of sorts. I'm in the minority of treaters in that I want to come out of the box swinging. I want to put you on the most effective disease modifying therapy that you're comfortable taking. And oftentimes I'm met with strange looks or resistance, or people being doctors will say, you're being a cowboy, you're being too aggressive. I'm not so certain. MS is a neurodegenerative condition. It's an incurable condition. But if we apply the most effective medicines up front, we have the best chance of wrangling it to the ground.
Other branches of medicine, it's to the best of my knowledge, you don't turn up and they say it's cancer, but you know what? Give it a couple months. Let's see how your tumors get on. And I suppose, and certainly in the UK, there's a set of guidelines, which essentially you have to get sicker to win the reward of better medicines.
The cancer example was outstanding. And here in the United States, non-Hodgkin's lymphoma used to be a death sentence. You had a 5% 5-year survival rate. And there was a shift in treatment where instead of using one drug and waiting and then using another drug, they came out with something called RCHOP, RCHOP. That's 5 types of chemo, all given at the same time. Wow. It's a very, very rough treatment, but now the 5-year survival rate is 95%.
Yeah.
And I think what you're touching on is this flawed concept that we've both talked about on our channels about the escalation model, which at first blush sounds lovely. I'll put you on a low efficacy medicine, honey. And if things go well, then I'm a great doctor and you're a great patient, and that's a fine medicine. And if things don't go well, please don't worry, sweetheart. We'll simply upgrade your medicine to something that's more effective. Well, pause. When you say it doesn't go well, that means irreversible brain damage. And that also assumes that I am all seeing and all knowing, I'll catch all the disease activity, and that you are fully aware of any bad things that happen. All 3 of those things are, excuse my language, bullshit. And I think it leads to people accruing disability under the supervision of a clinician, which is frankly infuriating.
There's no take back with MS.
It's like saying, have sex without a condom, and if you get pregnant, then we'll give you a condom. It's really doing things in the wrong order. You have just gone through 2 rounds of Lemtrada, alemtuzumab. Here in the United States, I lament that you can't give someone Lemtrada straight out of the box. The way that the American system is constructed is you have to fail two drugs before you're eligible for it. And I want to point out that people don't fail drugs fail people. But
yeah, it's like, oh, here, am I ready for my test?
You just went through that, and it was your 5th disease modifying therapy. Just for people listening, can you share your experience? So many people are terrified of the side effect profile of Lemtrada that they won't listen to the benefits and the efficacy. And I think that, you have an understanding of that.
I mean, again, it's individual. I say it in the video to people with side effects. If you read the data sheet for an over-the-counter medicine that you can buy in a gas station or petrol station, Nurofen, ibuprofen, whatever you call it,
you'd be terrified.
I don't know anybody, me included, until I looked, who'd actually read the leaflet. And it was like petrifying. Personally, to answer your question, out of the 5 drugs, and this is going to sound stupid, I have had the fewest issues with Lemtrada, and I've had Rebif, Copaxone, Tecfidera, which is probably the most side effecty, shall we say, ocrelizumab, and then alemtuzumab, Lemtrada. And I mean, there's no doubt, Lemtrada takes you out, shall we say, for 3 to 4 weeks. You're just, but I'm not sort of breaking out in hives and dying and getting these ghastly, oh my God, I might have to go to hospital things. It's just, people just say to me, keep saying, take it easy. Because the first time I had Lemtrada, I felt okay after 4 days. And so I went for a 4-mile walk and nearly wrote myself off. I lay in bed for 3 days with somebody going, that's not a good thing to do.
It takes a careful, thoughtful person to recognize, I'm going to accept upfront risk and complexity in the exchange for potential quiet disease in the absence of retreatment.
My friend Rachel, who had stem cells, Aaron, and she had a great phrase. She said, I'm rolling up all the risk up front. I'm
Yep.
taking all the risks now because you don't have to take Lemtrada more than twice generally. And the whole point is it's an, they call it immunoreconstitutive therapy. So as opposed to suppress things, it tries to wipe things out and help your body start afresh, like stem cells.
Yep.
But that was her point, was roll the risk up front. There is risk with everything. She's just going to take it now to have a better future.
If I had MS, I would want to probably induce myself with alemtuzumab. I might do something fancy and take Tysabri for 3 months to get all the cells where I can get to them, and then take Lemtrada. And bluntly, I would probably give myself 3 rounds. So I wouldn't stop at 2 rounds. If I continue to have disease activity after 2 to 3 rounds of Lemtrada, I would want a stem cell transplant. And people listening might say, "Oh my God, he's crazy." But I'm saying that with 20 years of experience treating this disease, knowing what we both are talking about, knowing what I know now, I think that's the most rational way of trying to address this.
Hey, one of your colleagues over here in the UK, Professor Giovannoni, he's on record as, and I put this, with the reference, he's on record, he's written it down himself. I would have stem cells if I was unfortunate enough to have MS. I go straight for stem cells. So what I'm hearing is you guys, the doctors, and I referenced two doctors that I know with MS, one who's gone straight on to cladribine and one who's moving from natalizumab to stem cells. He's obviously a mini Boster, but it's you know, it, these guys aren't messing around. They know what's coming down the pipe. They know that it's better probably to put up with a bit of, shall we say, crap up front for a better long-term outcome.
My point here is when you look at someone that's been in the game for a while, whether that be a patient who is thoughtful and well-read, whether that be an attentive clinician who is trying to help families do the best they can, or whether that be the growing accumulation of data, it all points in the same direction, that the earliest application of the most effective therapy is the best bet for long-term outcomes. And that doesn't mean that every person needs to sign up for stem cell transplants and Lemtrada, but it does mean that we need to wake up a little bit, and we need to be aware that this disease is insidious, and you might escape severe consequences for 5, 10, 15, even 20 years. There's no such thing in my mind as benign multiple sclerosis.
It's 2023, and we know this. And on Reddit this morning, I was going back and forth with a guy who said, well, my doctor's told me it's mild MS, so he wants me to start on Rebif. And you're thinking, oh, yeah,
Bullshit.
it's just like, oh, you've broken your leg, but we're going to tape it together for the few popsicle sticks to see how it goes first.
If somebody's listening to this, my take home is not that they should run out and take a stem cell transplant or alemtuzumab, but my take home would probably be that they need to be thoughtful and thinking about their goals 20, 30, 40 years from now, and they need to not minimize what's going on. And
Do you know
they
what my
need to
take
be
home
very,
is?
very.
They need somebody like you, a neurologist, yeah, their neurologist needs to be concerned and interested and genuinely interested in what are your goals for the future, because how you medicate now, and also they need to be genuinely concerned and interested that you truly understand how MS goes. It was Proshmara saying, 9 out of 10 people don't do well on it without drugs. So therefore, what's that Clint Eastwood thing? Are you feeling lucky, punk?
Yeah.
Are you feeling lucky to personally say no, no, no? I reckon I'll be in the good end of that 90%.
Yeah.
I'm a cynic. I'm just thinking, nope, I'm gonna try and step all over it as much as possible. I think a lot of people expect if you're not peeing yourself uncontrollably, if you're not having massive problems walking, if you're not, then you're fine. It's like, no, you need to rejig your lens because even in my world, there's some pretty crappy things going on for me. And how, again, thinking, fatigue, they matter to me. And I want the doctor to treat my MS, not MS in general, and then lump me into the, aren't you a lucky dude?
Just because you've had MS for fill in the blank time doesn't mean that the game's over and that we've missed our opportunities, because I'm of the opinion that we can still intervene. I think you're a great example. Here you are in your very early 50s, and you've opted
That's kind.
to take alemtuzumab, right?
Yeah.
And so I think I don't want someone listening to this to think, well, that ship has sailed and there's nothing else I can do. I vehemently disagree. I also think that there's a bit of ageism in amongst MS treaters. And they'll say, well, the risk is getting too significant. We should back off now. And I disagree with that as well.
That's a second thing, which, because I'm of this youthful 54, I mean, I barely notice age.
I think MS neurologists sometimes drag their feet early on when they should come out of the box with a more clear description of what MS really means and how we need to treat it aggressively. What I'm seeing more and more is patients are being told, well, honey, as you get older, we really need to back off. You shouldn't be on that B cell depleter for so long. God forbid you explode. Or, now you're aging out of the disease because you had your 55th or your 60th birthday. And I think that's also missing the point. I'm of the opinion that we should absolutely never treat someone after death. I think that's foolish, and I don't agree with it.
Well, it's a waste of money, if anything else.
Well, also the drugs don't work, or they haven't been studied after death. But if you have neurological features that you like having an orgasm, or smelling something, or seeing, or moving your hand, and you want to maintain those, I think that we need to intervene to make sure your immune system doesn't attack them. Can you talk about the rationale of continuing to be aggressive with your care despite being a very young 54-year-old?
I use the example actually of a friend who, at the age of 69 or 70, was started on Mavenclad, cladribine, and you know, not
Brilliant.
some wackadoodle crackpot yeehaw cowboy doctor. The person who started on it is a reputable, published, specialist MS consultant, and in the UK. But they take the view, like you, that the ship hasn't sailed. You didn't miss the last ship. Tough luck,
Yeah.
and it's treat you until treating you doesn't do anything, or you say don't treat me anymore. I mean, this is the other benefit of the immunoreconstitutive therapies is you treat hard and fast up front, and I'm being quite loose with what I'm saying, but you treat hard and fast up front, and then it's not really a thing. I mean, I have friends, several friends who've had lemon lemon. One of them has had 3 rounds, a couple of them have had 2 rounds, and it's just they can reflect on the fact that, yeah, they were diagnosed with MS, but they're just getting on with life. They know that it may not last forever, but they know that they've done their level best to sort of put the bugger that is MS back into its box for as long as possible. And they've still got the option of potentially a third round. But it's so different to the people who are forced to live in their disease. Every 6 months you need an infusion, or every 4 weeks you need an infusion, or I mean, you can't get MS out of your head.
Or you need to inject daily, or you need to take a pill twice a day, or what have you.
Been
Now,
there.
yeah, I think focusing on this idea of giving Mavenclad, cladribine, later in someone's age is something that I increasingly love. And I think it's really important to point out that MS medicines, particularly the newer MS medicines, do way more than stop new spots and prevent attacks. They slow disability progression. They maintain functional reserve. You preserve the reserve. And I think so often patients aren't told that, and they get this 1990s idea that if there's no attack, then everything's fine.
Why aren't they told, Aaron? Is it because their doctors don't know it? Their doctors don't put themselves. I mean, this is what I struggle with as a patient. Is I don't think any of you or your colleagues have evil intention. I think some people don't try as hard. I'm not sure. I think they stop engaging. They don't go too deep or something. It's
Yeah.
me in my life. It's whoever it is in their life. It's this young woman that was, there's no going back from where she is. There's no guarantee, but the data says it's less likely that she will be as disabled
Yeah.
as soon. And she's 30 now, so she's going to live for at least another 40 years, likely, and things are not going to get any better.
So this really speaks to a couple things. One is self-advocacy. So just because a given clinician is okay with allowing you to accrue disability doesn't mean that you're okay with that. And I think it's imperative that the human being says, no, I'm not okay with that. No, I would like to expect more.
That's
I
what I
also,
tried to get across in this video was, you can challenge your doctor. Don't be rude, but they should be on your page. And if they're not on your page, Time to find another doctor, in my humble
That's,
opinion.
that's exactly right. I mean, we doctors are like plumbers. And if you had a plumber that argued with you about where to place your sink, you dismiss them and find another plumber. So often, Dominic, someone comes to me and they've never heard of PIRA, progression independent from relapse activity.
Mm.
They've never had it explained to them that just because they don't have spots doesn't mean that they can't progress. And I'm not saying that it's all medical gaslighting. I think some of it is probably a lack of understanding on the clinician's part. But it's my hope that these YouTube discussions, the channel that I'm so proud of you for developing, and my efforts on social media help
Yeah,
wake people up a little bit.
the MS world doesn't, for whatever reason, seem to be advancing as fast. There's no sense of immediacy with MS. You're not going to die on paper. Everybody seems to think it's fine. Just go, let's take a deep breath, Or actually, it's serious, but in a different way. And it's serious over time. And it's unlikely that the neurologist you'll be talking to today when you're newly diagnosed is going to be the one looking at you in 20, 30 years' time.
Yeah.
Back to your point, you've got to be thinking of yourself. You're not here to upset people. Well, most of us aren't, but you're not here to make friends either. This is about you and your brain, and essentially every second that goes by, that's your brain.
It's a great point. Thanks for chatting with me. The video that you put out is impactful. I'll
Thank
have a
you.
link in the description below. Again, if you guys don't know Dominic and you're not following his channel, you're missing out. Thank you very much. I really appreciate your efforts.
Hey, Aaron, yeah, it's brilliant. You have
Thanks
a
again.
great time, and thanks so much.
Absolutely. Until the next time. Ciao.
You bet.